Welcome, everyone. Good afternoon or morning, wherever you may be joining us from. We're going to give it just a few minutes to allow people to join and connect to audio, and then we'll get started. Thank you all for joining us today. We're just giving it a few minutes to allow everyone to connect, and then we'll be getting started in about 1 or 2 minutes. Okay, well, let's go ahead and get started. I know we may have some others joining as we get going, but again, thank you all. Welcome. We are so excited to have you all joining us today, and even more excited to have our three amazing panelists and students and genetic counselors who are going to be walking through some of their great research projects today. But before we turn it over to our panel to start, I just wanted to share and thank you all as we kick off Newborn Screening Awareness Month every September. We are so delighted to be able to highlight a lot of the amazing work that these three students have done over the last several years, 2 years, some more recent than others, and just celebrate this work and the work that goes into bringing awareness to newborn screening. We're excited to be kicking off this month with this webinar, and we have a number of additional webinars and activities planned throughout the month. So please feel free to visit our website at either Expecting Health or Baby's First Test to learn more about these activities, and we'll be sharing some information about that as well towards the end of the webinar. But we will certainly jump in and get started because I know we have a lot to get through, and I'm super excited to be joined by these three wonderful individuals. So each of these individuals, and each of them will have some time to introduce themselves, but I'm going to just quickly go through who we have with us today. So first joining us is Morgan Hurst, who is a current joint genetic counseling and Masters of Public Health student at the University of Michigan, and who recently just returned from a trip to Nepal and is going to be sharing a little bit about her work there regarding newborn screening. We're also going to be hearing from Emily Henderson, who is a recent graduate of the Mount Sinai Genetic Counseling Program. And we'll also be hearing from Maya Del Rosario, who is currently working in the cardiovascular genetics clinic at Boston Children's Hospital. So each of these individuals has participated in our newborn screening student ambassador program. So through Expecting Health, over the last 3 years, we've hosted around 20 students for a 1-month immersive rotation, learning in-depth information about newborn screening, everything from the role that both states and the federal government have in newborn screening to the experiences that families may have as they're navigating the newborn screening system and everything in between. And so all three of these wonderful students participated in that program and completed that program. And to date, over the 3 years, we've had over 60 students who have participated in that. So it's a program that is near and dear to my heart personally as a genetic counselor. And so getting to work directly with genetic counseling trainees and really deepening their understanding of public health and the newborn screening system has been something that we're extremely excited and very proud of. So if anyone has questions about that, happy to connect with you one-on-one at another time, but definitely a program that we love to celebrate this month. So I'm actually going to, one moment. We're going to start first with apologies, Morgan. I'm going to turn it over to you, Morgan, if you want to say a little bit more about yourself and then jump in. We'd love to hear from you.
Sure. So just to reiterate, my name is Morgan. I am a third-year genetic counseling student and dual degree public health and health behavior health equity at the University of Michigan. And I think you covered it. I just got back from Nepal. This research is more in its early stages, maybe than the other folks here today. So thanks for handling it with care, but I'll go ahead and get started.
Morgan, are you able to see the slides?
No, I'm not.
Uh-oh. Can Emily, you see the slides?
Oh, okay. All right. Okay, now I can.
Got it. Let
Um,
me start.
Perfect.
Yeah,
Sorry about that.
that's
So
okay.
as you all know, newborn screening is really a pivotal public health intervention aimed at sort of early detection and management of congenital and genetic disorders. It's essential for reducing infant mortality and morbidity, which is one of the main reasons that I was interested in this work. There are well-established newborn screening programs in a lot of countries, but the implementation of newborn screening programs in lower resource or low and middle income countries such as Nepal represent sort of some unique challenges. So what I'll be presenting today sort of objective is to identify existing resources, access to knowledge levels, infrastructure readiness, and pinpoint challenges within the existing systems that exist in Nepal. Nepal has a really diverse geographical and socioeconomic landscape, which represents some pretty unique challenges in implementing uniform screening healthcare services, including newborn screening. So the Nepal in general is a very diverse region. As you can see, this is taken from the WHO. Oh, can you go back? Sorry. There are known benefits of newborn screening and early detection and management of various different congenital disorders. Again, its adoption in LMICs or low and middle income countries is underdeveloped or under-resourced. And a lot of these gaps arise from systemic challenges, things like inadequate infrastructure, limited healthcare, professional training, resource constraints, and studies in the past have indicated that effective newborn screening can really lead to substantially improved health outcomes, not only for infants and neonates, but also long-term outcomes. But again, implementation barriers are sort of yet to be explored in LMICs. Looking at the map, so you can go forward one, just to orient you, Nepal is a country with 125 ethnic groups, and it has pretty diverse geography. So the south is a little bit more flat. There are hilly regions in the center, and then there's mountains in the north. There are several major caste systems, and some of the caste systems have associated genetic conditions, which are sort of relevant in thinking about which genetic conditions would be included on a theoretical newborn screening panel. Again, newborn screening is not available in Nepal right now, but a small number of newborn tests are sort of able to be sent to laboratories in India for analysis when IEMs or inborn errors of metabolisms are suspected. And especially this really only happens when there's suspicion of the mother being ill or when infants are critically ill or dying. You can go forward. So I spent my time at this hospital. It's called Dhulakal Hospital, and it's located in Dhulakal, Nepal. It's really a cornerstone of community health for the residents and the surrounding residents from more rural regions. People will walk up to 2 days to get care at this hospital. And although Dhulakal Hospital is pretty heavily involved in community-based care and has a lot of ongoing research projects, things that aim to improve maternal and fetal care, there's really not a lot of research that's been done yet to query newborn screening and how newborn screening might be impacted specifically by gender norms, which is something that came up in a needs assessment that I did there. So over a 5-week period, I conducted a needs assessment. I documented knowledge, attitudes, assessed potential need for newborn screening and other services at Dhulakal Hospital. I surveyed physicians across all areas, including pediatrics, OB-GYN, really into like cardiology, orthopedics, all of these things. And in addition to literature reviews, speaking with patients, attending meetings, was able to sort of collect field data. And this data collection has been sort of organized and has allowed us to look more deeply into which areas require a little bit more or which areas there are gaps in for research development. So moving forward, I also want to sort of rewind to talk about the way that I'm thinking about this work. So a lot on this screen, I know, but taking sort of a public health lens to things, we know that societal, community and political and interpersonal factors contribute to infant well-being in Nepal, as with anywhere. And it's really difficult to expect change within a hospital system, much less a government system, without looking at holistic systems levels communities. So implementing newborn screening at Dulakal Hospital in particular could provide greater structural and community support during and after a loss of an infant or while treating. And so the goal was really to center the experiences of physicians and families who have experience with infant death in Nepal, which might be preventable if newborn screening is possible to implement there. And this really would be sort of a long-term approach, long-term response. So the work that I propose to do is sort of like a drop in the bucket of what will hopefully be a longer-term project. And we'll take more of a root cause approach, things like targeting income and education determinants, which resources, how to put resources into long-term change, using community members as sort of the drivers of that. Moving forward. And then one more. There's just another graphic. Oops. Forward to. We're just looking at the social ecological model here. But sort of when thinking about implementation of newborn screening in a country and region that's not my own, it was important to look at what are the resources, infrastructure, the people, administration, all of these things that lead to policy and a potential effectiveness for implementing long-term sustainable newborn screening. And so this is sort of the foundation for which we organized our needs assessment and which we're sort of continuing this research. So we sought to identify sort of strengths, gaps, potential pathways for enhancing newborn screening efforts in the country, with the goal of sort of providing novel insights and recommendations that will pave the way for collaborative efforts in the future, not just for Nepal, but for other LMICs that don't yet have newborn screening. There's that, and then we can go forward one more. All right, so this is just an overview of what newborn screening sort of looks like. I'm sure you're all familiar with this, but it sort of goes from screening to long-term rehab. This is just to sort of highlight that this is a very public health system that really is a system intended to reduce infant mortality within a wide range of disorders. Things like hemoglobinopathies, endocrinopathies, inherited metabolic conditions, and congenital hearing loss. And the way that we imagine this happening is sort of a stepwise approach, identifying the conditions that are most common and that can be both identified and treated at a low cost because there are sex and gender differences in terms of treatment. So the specific aims of this work are primarily, can move forward one slide, perfect, to understand and evaluate current understandings, shed light on issues of access and diversity, identify potential sex and gender-based barriers to newborn screening, ensure that newborn screening research and implementation is sustainable, longitudinal, and bidirectional. That's that community-driven approach that I was talking about. Provide a robust range of perspectives to offer these reasonably rounded ranges of solutions. And moving to the significance, sort of some questions that arose are, can the recommended uniform screening panel be used as or transformed into a culturally competent tool to provide better healthcare and reduce infant mortality. Another question is what or whose interests are at conflict with one another? And lastly, we hope to understand barriers that might ultimately get in the way of ethical and equitable practice. So I went to Nepal hoping to assess systemic challenges by assessing readiness at this specific hospital, Dulakal Hospital, to implement newborn screening, with the hope of identifying structural and resource gaps, evaluate training needs of different providers, given that genetic testing services are not available, and sort of gauge institutional support for such activities so that if there is need for more governmental input or resource backing, that we can pursue that appropriately. And go to the next slide. So another sort of WHO considerations, we need to think about context, right? So if and how newborn screening is established in Nepal is sort of dependent on that context in which it's being introduced. And our needs assessment revealed several community needs, free and accessible education before, during, and after pregnancy, access to government insurance, support groups, genetic testing, sex education, the importance of prenatal care, and breastfeeding education are just a few. And increasing education about newborn screening could, in fact, be its own intervention that could reduce infant mortality by promoting quality prenatal care. Can move forward one slide. This is also just sort of a reminder of what I'm hoping to keep in mind throughout the duration of this project. That outcome process and political struggle are key features that we'll be grappling with, my own whiteness included, as one of those things that building and breaking power will things that I'm grappling with as a student engaged in global public health work for the first time. And moving forward, this is how this maybe looks in practice. So again, a lot on this slide, but thinking about our assumptions, inputs, activities, outputs, outcomes, and impact, I likely will be unable to see the impact in this work, but I've identified some of the key features of the assumptions. You can press enter and I'll get some red boxes. There we go. So yeah, we're targeting providers. I consider myself an external agent working with community members. We're hoping for active participation in the reform process, more effective distribution of healthcare resources, and then those top three outcomes are sort of somewhere in between there as to what we hope to get out. So, final key features. We're looking at what we collected already are demographics and what you read there. Click forward. The study population is primarily healthcare professionals, as I alluded to. Move forward. We conducted a readiness assessment, which included infrastructure evaluation and then understanding personnel training and expertise. Identified barriers. In the future, we're hoping to outline strategic recommendations with community members, hoping that this will inform policy development and track newborn health outcomes. And then the tools we used were both survey and semi-structured interviews or needs assessment. In the future, we're using survey and semi-structured interviews with providers at both Dulakal Hospital and outreach clinics to understand sex and gender-based structural barriers to accessing newborn screening. For reference, we know that infant mortality rates are quite high, with over 30,000 deaths per day. There are skewed sex ratios, which is why I'm interested in this concept of understanding gender-based differences, sex and gender-based differences to access to care. There are still home births, so considering which patients will be treated and which ones will not have access to newborn screening is an important one. And then there are certainly other dimensions of infant mortality that I won't be able to address. But key here is the skewed sex ratios. There is typically 121 male births per 100 female births, which this data comes from a wide range of different hospital systems, so is highly reliable and is something that we should consider, that although we're not thinking about preventing termination based on sex, there is differences in treatment based on sex. Sorry, you can go forward. This is just a Gantt chart thinking about how this project will look over the next year. And then to close out, I just have this amalgam of the different ways that all of the different parts of the community are interacting with the public health agency, which we're calling newborn screening. So we're thinking about the NICU, obstetrics and gynecology, pediatric units, in Dulakal Hospital in Nepal. And eventually the goal is to expand newborn screening to other public and private health systems in the country, their outreach centers in more rural communities, and really maximize that impact, not only to create providers that are competent, but healthcare systems that are able to be tailored and support different patients and offer testing, newborn screening to everyone, and that no one is left out. And I guess the question I'll leave us with is, if we're providing options for identifying and managing or treating congenital conditions, who might be left out of the conversation, who may not have access to what we learn, and how can these concerns be mitigated? So this is sort of in the back of my mind as I'm continuing this work, and keeping in mind how I may or may not be inadvertently increasing inequities. And with that, I'll pass it along to or I'll pass it back to Mariana. Thanks.
Wonderful. Thank you so much for walking through that, Morgan. And I know I certainly learned a lot just from that presentation about an area in a country that I personally don't know a lot about. So I can only imagine how much work and effort has gone into getting to where you are, and look forward to what's to come from that. I know if anyone listening has questions, please feel free to drop those in the chat box. I didn't mention that earlier. We will have a little bit of time at the end to address any questions that may come up. And if we don't get to all of the questions, then certainly we can follow up with you following the webinar. But please feel free, if you have questions for Morgan, we'll hold those till the end. Drop those in the chat box and we'll come back. So next, we are going to be hearing from Maya Del Rosario. And give me just a second, Maya, to get to your slides. And we'll go from here. Okay, cool. There we go. So I'm going to turn it over to you.
Perfect. Thank you so much, Mariana. So hi, everyone. My name is Maya. I am a newly certified genetic counselor at Boston Children's Hospital in the Center for Cardiovascular Genetics. And I'm really grateful for the opportunity to be able to share my graduate research with all of you. Next slide. Just to introduce myself a little bit more, I got my undergraduate degree in neuroscience and psychology at Skidmore College in New York. And then I made a move to Boston to work as a research assistant in Boston Children's Hospital, where I worked on various projects, including BabySeq and the Manton Center for Orphan Disease Research. And then I matched at Boston University at their genetic counseling program, where I received my training. And now I've actually found my way back to Boston Children's Hospital as a clinical genetic counselor in their cardiovascular genetics center. Next slide. Just to briefly summarize newborn screening as it relates to my research, I know you're probably all very familiar with this, but it's a public health program that utilizes a dried blood sample from a heel prick within a baby's first couple of days of life to screen for certain health conditions. And overall, the goal of this program is to screen for conditions where disease can be prevented or outcomes can be improved for children in the early days or years of life that would otherwise not be detected until typically irreversible symptoms begin to present. Although a government agency, HRSA, has compiled a list of now 38 conditions that they recommend each state screen for, called the Recommended Uniform Screening Panel, or the RUSP. Each state has the agency to determine which conditions they'll choose to screen newborns for, which is why Baby's First Test and Expecting Health has been an exceptionally helpful resource for me in this research and in practice for both patients and families and providers. Next slide. So currently, newborn screening is done by looking for specific biomarkers or analytes in the blood that can be detected through biochemical testing. And although historically this has been a very successful method, there are some limitations to that testing, including high rates of false positives, the need to confirm diagnosis with follow-up testing, and that some conditions that would otherwise meet Wilson and Younger criteria for newborn screening don't have an easily identifiable biomarker. There is, however, growing interest in seeing if genomic sequencing can be used to potentially expand newborn screening to reduce the rate of false positives, offer diagnoses that won't require additional confirmation, screen for conditions that caused by known genetic variants that may not otherwise have a biomarker, and provide additional health information for at-risk relatives. Next. So preliminary research has been done assessing the perspectives of other stakeholders in newborn screening, including parents, physicians, and rare disease experts, but there has been no exploration yet of genetic counselors' perspectives. And so since genetic counselors are so often involved in the discussion of positive newborn screening results and family planning, my research question for this project was, what are the perspectives of genetic counselors regarding the use of genomic sequencing to expand newborn screening? And so for my capstone project, I created a survey that was completed by 176 genetic counselors who were practicing in the United States. The survey was divided into 3 sections. So section 1 evaluated participant agreement with a 5-point Likert scale. This section included 26 statements about the types of conditions that could be screened for, as well as the benefits, limitations, and practical and ethical considerations of genomic newborn screening. And the second section evaluated participant endorsement for 25 specific genes and their corresponding conditions that potentially we could screen for with genomic sequencing. And the 25 genes that I included in this survey were based on those with high levels of endorsement from rare disease physicians from a prior study by my advisor and mentor for this project, Dr. Nina Gold, who was part of my capstone committee. And then section 3 we elicited demographic information from participants as well to see if there were any relationships between location, practice area, and other variables and our responses. To add a bit more context, we evaluated genetic counselors' attitudes towards types of conditions to screen for based on age of onset from early to late, treatability from the only treatment being supportive care to a cure, the existence of a confirmatory test from diagnostic to unavailable, and the penetrance of a condition from low to high. Next slide. So we asked respondents also to evaluate whether they endorsed a specific gene or a condition for genomic newborn screening. And these genes and conditions were grouped and presented by clinical area. So 15 were metabolic conditions, like many of the conditions that are currently on the RUSP right now. And then the remaining 10 were from other clinical areas. Next slide. So regarding support for genomic newborn screening, we found that 93% of our respondents agreed that expanded newborn screening should include conditions that are treatable, but not currently on the RUSP. 92% agreed that genomic newborn screening would benefit individuals who have a genetic condition that would have been missed on standard newborn screening. And 88% agreed that genomic newborn screening would help inform family planning. Next slide. Regarding limitations and concerns for genomic newborn screening, some of the highlights were that 97% agree that there's a need for educational resources for providers regarding new conditions that could be added to the newborn screening panel. 85 agreed that legal regulations and protections regarding privacy and storage of genetic data should be in place before expanded newborn screening is implemented. And then 77% disagreed that their clinic, or the providers that they or their clinic refer to would be ready for increased clinic volume for high-risk patients and their families that would be identified by expanded newborn screening. Next slide. There were also significant differences in attitude based on respondent region. So I divided our participants and respondents up by NSGC region in the United States, and respondents from region 1 agreed that newborn sequencing should include conditions that are treatable even if they have low penetrance, more so than the other regions. And respondents from both regions 1 and 2 agreed that newborn sequencing will reduce mortality of genetic disease, more so than the other regions. And then respondents from region 2 agreed that newborn sequencing would improve health equity more than other regions. And respondents from regions 4 and 5 disagreed that expanded newborn screening would improve health equity more than the other regions. Next. Specific conditions that received the highest level endorsement were OTC, MPS II or Hurler syndrome, DMD, and hemophilia A and B. The conditions with the lowest endorsement were cerebral creatine deficiency syndrome 3, which is an ultra-rare condition, but did actually just recently get added to the RUSP, as well as 2 other potentially lesser known or less common genetic conditions. Next slide. So from this survey, we found that, like previously surveyed physicians, genetic counselors largely supported genomic newborn screening for treatable and childhood onset conditions. Physicians from the prior study, however, offered a higher endorsement for the addition of treatable but adult onset conditions rather than respondents from this survey. And I think that this discrepancy in endorsement for screening adult onset treatable conditions may come from differences in practice guidelines and code of ethics, where those for genetic counselors focus really heavily on non-directiveness and autonomy, while those for medical geneticists offer more guidance related to disclosure of adult onset conditions if they're actionable later in life. A second finding is that respondents from the Northeast expressed higher levels of agreement that genomic newborn screening would improve health equity and reduce mortality, which may be a reflection of high density of hospitals and treatment infrastructure, higher availability of genetic counselors, and maybe perhaps less restrictive policies around reproductive options. And the last finding I'll mention is that the genes and conditions that receive the highest endorsement are those that may be more frequently discussed in genetic counseling treatment programs. And those with a lower endorsement may have received less support just because genetic counselors were unfamiliar with them rather than because they disapproved of them being added to newborn screening. Next slide. So in conclusion, genetic counselors largely supported expanding newborn screening with genomic sequencing. Most agreed that conditions that are childhood onset and either have a clear treatment or management or guidelines should be considered with this addition. And although attitudes towards potential benefits, limitations, ethical and practical considerations were generally consistent amongst respondents, some attitudes did vary by practice region, with those in the Northeast demonstrating the most enthusiasm for expanding newborn screening. And additional development of clear inclusion criteria for genetic conditions to add to genomic newborn screening and investigation of ethical and practical concerns must absolutely be considered as the feasibility of genomic newborn screening is explored. Next slide. So thank you so much for giving me the opportunity to share my research. Just as a little bit of a plug, I'm actually really happy to say that the manuscript of this research was just published yesterday. So if anyone wants to read it, it is open access. And I am putting my email here because if anyone has any questions about genetic counseling research, research in a program, or life after graduating, feel free to reach out. I'm happy to answer any questions.
Amazing, Maya. Congratulations. What perfect timing for, I'm sure, an incredibly long and a hard amount of work. So congrats on that.
Thank you.
I'm jotting down some questions that I have, so I will come back to those in just a little bit, but super interesting. And I think both of you have already highlighted such vast focus areas and diversity of topics that you're interested in. And, I just think that's incredible that through the different programs that each of you are a part of, you can really touch on extremely different aspects and elements of newborn screening, but also beyond that, the scope of just general practice and health. So last but certainly not least, we are going to be hearing from Emily. And Emily, I'm going to stop sharing so that you can go ahead and share your screen. And again, just while we're loading that up, as a reminder, if you do have questions, please feel free to drop those in the chat box. And I'm happy to come back to those at the end of the webinar.
Can you see my slides and hear me okay? Okay.
You sound a little bit far away, Emily. I don't know if you can.
Sometimes when I turn my audio back on, it gets a little. Okay. So this research project was part of my thesis at Mount Sinai, and the selected findings I'm going to present today are perhaps adjacent to newborn screening specific research, but I think are really relevant amidst the evolving landscape of newborn screening for MPS. And they're consistent with the lessons I learned from the family leaders that shared their stories with our student ambassador cohort this past spring. So MPS and ML are lysosomal storage disorders. This is a heterogeneous group of childhood onset disorders that severely impact a child's development, cause progressive damage to different body systems, and can be life-limiting. So the incidence rates vary among the specific disorders. I have those here, but overall, these are rare conditions. I selected this population because there has been a considerable increase in families of children with these disorders using social media to share their stories. And it's hypothesized that the increased frequency of social media posts, viral campaigns, and disorder-related hashtags has amplified viewership, engagement, and awareness of MPS among the public. So in terms of the current state of newborn screening for MPS and ML in the United States, MPS 1 and 2 are the only ones included on the RUSP. MPS 1 was added in February 2016, and it's the most commonly screened for across the various states. Hopefully by 2025, all states will be screening for it. MPS 2 was added to the RUSP in August 2022, and as of now, 8 states are screening for it. California just began screening last month, and Kansas just began screening this month. No screening for MPS 3 at the state level due to lack of approved treatments. MPS 4A, 6, and 7 have enzyme replacement therapies available, and these conditions were listed as pilot candidate conditions by the Newborn Screening and Translational Research Network. So these are essentially very close to RUSP ready. West Virginia is the first entity to screen for MPS 4A, but other than that, no states routinely screening for these 3 conditions. I will mention Taiwan is screening for MPS 4A and 6, and there have been patients identified in Taiwan with MPS 4A, but not 6. And I'll also just mention a few pilot program screening with consent for some of these conditions. We have Screen Plus in New York, offering screening for MPS 2, 3B, 4A, 6, and 7. I believe MPS 3A, which is the most common and aggressive form of Sanfilippo syndrome, was intended to be added to this list, but has not been yet. Also in New York is the Guardian study, which is offering screening for MPS 1, 2, 4A, and 4B, 6, and 7 in their Group 1 conditions, and MPS 3A and 3B in their Group 2. And then Early Check in North Carolina is offering screening for MPS 1, 2, 4A, and 6 in their Group 1 conditions, and 3A and 7 in their Group 2. No state screening for mucolipidosis 2 or 3. Enzyme replacement for ML has been explored, but no treatments have been of significant long-term benefit for these patients. So previous research on social media and health communication has really focused on information seeking in private social media support groups. These are groups that are typically not viewable to the public and are specifically meant for members of the rare disease communities and their caregivers and families. So most times you need to apply and be approved to join these groups, kind of like this example here of a Facebook group specifically for parents of children with Sanfilippo syndrome. So it's known that people use these closed groups to exchange knowledge, solicit advice, and discuss shared experiences. But we really wanted to investigate how and why people are using personal accounts to publicly share knowledge and experiences pertaining to caring for a child with a rare life-threatening condition. So I just included 2 examples here of parents of children with public profiles dedicated to their daughters with MPS III on Instagram and TikTok. Maybe some of you recognize them. They have over 1 million followers across their different platforms. So the following aims were developed. We wanted to identify the motivators for sharing user-generated MPS or ML-related content on public social media pages. We wanted to assess the impact and therapeutic value of publicly sharing a child's MPS or ML diagnosis and journey on social media. And we wanted to distinguish the content shared on the public pages versus in those private groups. So we started with an anonymous electronic survey that was branched based on their response to how they are using social media. Are they in private groups? Do they have a public page? Both or neither? And the survey also included some open-ended questions about why they share on a public social media page, the positive and negative outcomes of sharing publicly, and how sharing has affected them and their family. And respondents were also invited to participate in a qualitative, semi-structured interview to further explore these concepts. So I have lots of interesting data and some cross-analyses I won't be able to get through today. I'm more than happy to connect with anyone that might be interested to hear more about those. But for the rest of my time, I'm just going to highlight some of the big takeaways from the thematic analyses. This was the breakdown of our survey respondents using only private groups, only using a public page, using both or neither. So you can see a majority of our respondents were using both the private groups and a public page dedicated to their child or family member with MPS or ML. So responses to the open-ended survey questions were coded, and these were kind of the key themes that arose as motivating factors for sharing their child story publicly on social media. And I put gold stars next to the themes that I think are particularly relevant for families looking to have an impact in the newborn screening space. So connecting with other rare disease families who have similar experiences, such as others who have been affected by newborn screening, and to be a part of communities that provide support. They use public pages to share information about the condition, updates about their journey and their lived experiences. They share publicly to impact and motivate others to join their cause, and they're motivated to raise awareness about their child or family member's condition and to promote advocacy efforts. So I just wanted to share a quote from one of our respondents. I know there's a lot of debate about sharing your children on social media, but I think it's different with rare disease because it's so important for us to raise awareness and promote advocacy and fundraising. It's a matter of life and death for our children, so we need people to support our cause. We are rare, so we need to build numbers within the general public. I think this kind of encapsulates what a lot of families are feeling, maybe not right away after receiving a diagnosis, but once they've reached a certain part in their own journey and acceptance of the situation, they have that space to work towards a larger purpose of helping others that may be on that same journey. And that can mean helping more families reach an earlier diagnosis through newborn screening. They also reported sharing publicly to increase the reach of fundraising for research efforts or to collect personal donations for medical equipment or other expenses. And lastly, they share publicly to create a legacy for their child or family member who may have a limited life expectancy. So this word legacy was a really powerful term that parents and families reference when talking about their purpose and drive for enacting change, especially after losing a child. So this word legacy recurred in many responses from families in this survey. This idea of creating this presence that lives indefinitely online and creates ripple effects of change in communities, states, countries, even around the world. It's something that families feel they're doing by publicly sharing their stories on social media. In terms of the impact people hope to have when choosing to share their story publicly, they reported the desire to educate others, promote awareness about the condition and the associated challenges for families. They want to inspire their physical community, like their child's school, their church, their neighborhood, their coworkers, to become allies that are involved in advocacy and policy efforts. So they hope that by sharing the story publicly, it reaches someone that might have never heard about this condition or newborn screening before, and it motivates them to care and increases public awareness and calls for funding, action, and systemic change. Again, this idea of creating a legacy for their child and leaving an impact that lives on. So this was another quote I wanted to share. It's a pretty cool feeling to make an impact on the world like that, all while helping to advance the fight against Sanfilippo that one day may save my kid's life. And if not his life, then another kid's life down the line when there's a cure for Sanfilippo syndrome. And lastly, people want to empower and provide hope for other affected families in similar situations. So a lot of subjects discuss sharing publicly as a way to reciprocate what they found to be helpful in their own journey, and they want to provide that to someone else. For the sake of time, I'm just going to skip the second part of this aim, which looked at assessing the therapeutic value of publicly sharing. But we know these families often have feelings of fear, stress, frustration, uncertainty, vulnerability, loneliness. So subjects did report that sharing publicly relieved stress. It promoted feelings of empowerment. It was emotionally healing. It helped them process their complex feelings and even helped them overcome the fear of talking about the diagnosis. My final aim was to distinguish the content shared on public pages versus the private groups, and there were kind of two main schools of thought here. One being that there was no real difference in what they were posting on a public page versus in the private groups. They are sharing their life openly in hopes that it'll reach someone and make a difference within their lives. So whether that's inspiring someone to become more educated about the challenges facing rare disease families, to recognize the signs and symptoms of these conditions, potentially in their own child or others, to be inspired to donate to research or fundraisers, or to join a cause such as supporting the nomination of a condition to be added to newborn screening. They feel that by sharing that same information they share in a private group on their public page, it's a way to expand that impact. On the other hand, some subjects reported that what they share in a private group is more sensitive. It's more specific, targeted discussions about treatments, recovery from surgeries, side effects from medications. They want to keep those conversations guarded within the community of other affected families. They might also be using those private groups to specifically connect with another affected family, to find a specialist in their area, to stay up to date on research, clinical trials, legislative and advocacy efforts in their state. So they brought up that they tend to feel safer in the protected space of private groups, and that the energy tends to be a bit more positive compared to the response they receive when they open up and share their story publicly. Just want to say a disclaimer, that is a theme that arose in this small study, but I'm aware that people have more complex feelings towards these private groups. There was a recent episode of the podcast titled The Rare Life, Our Complicated Relationship with Medically Complex Facebook Groups, that explored some of those other feelings, that they can be difficult to navigate, that seeing the progression of disease in older children can be triggering and not always necessarily helpful, that there's challenging scenarios like other members being judgmental or shaming, or maybe exhibiting toxic positivity, and that they really have to regulate their usage of them for their own mental health. So I just wanted to mention this because I think as genetic counselors, healthcare providers, we can be better equipped to discuss the core values and concerns of families and help them evaluate their own decision to seek and share information in these spaces, and even might be how those change over time. So just to briefly summarize, we're kind of witnessing a changing landscape of newborn screening for MPS right now. I anticipate that more states will continue to screen for MPS 2 in the coming years. That MPS 4A, 6, and 7 may be nominated for the RUSP as pilot programs continue screening likely diagnose newborns with these conditions. That secondary conditions like mucolipidosis 2 and 3 might be caught when screening for these conditions begins, and that advancements in treatments for MPS 3 might lead to the adoption of more widespread screening for this condition. So Dr. Kara O'Neill, she's the Chief Scientific Officer of Cure Sanfilippo Foundation. She recently said that a shift to newborn screening diagnosis will be required to give children a fighting chance. So early diagnosis in that newborn period is really what's going to allow families to immediately seek clinical trial opportunities and therapies that can provide them better quality of life and less pain and suffering. We know that social media plays an increasing part in the lives of families with children with these conditions, and that social media is a really powerful tool for storytelling. Families sharing authentic accounts of their lives online in pictures, captions, blog posts, short and long form videos, they are undoubtedly influencing public awareness, motivating people to hear their message, and inspiring them to become invested in their cause. I just wanted to point out Expecting Health series on YouTube. They have put together some videos for families looking for advice on advocacy and how sharing their story can support system changes in newborn screening. So this is a great resource for families looking to learn more about the different types of advocacy, how to get started, potential partners, and really the importance of storytelling. People might have different motivators for using those private group pages versus a public page, and they might choose to seek and share different things on these two types of pages. Both can be really valuable sources of connecting with others, advancing initiatives that are important to them, and increasing awareness of newborn screening or advocating for newborn screening for a condition their child's been diagnosed with. This specific population I discussed today that use social media to publicly share their stories are motivated to do so for a lot of different reasons. These include accessing networks of support, building online communities, raising public awareness about a condition and the efforts to enact change, connecting with others in order to educate, impact, and motivate them to become involved in fundraising and advocacy, and creating a legacy for their children that lives on and being a part of a greater purpose or a mission. Just briefly mention some future directions, ideas for related research, maybe a study that actually evaluates the content that's shared on those public pages. I think diving deeper into the ethics of sharing information about your child on social media, especially in the case of children with cognitive impairments, limited life expectancy, that can't really consent to their parent sharing these intimate moments of their lives, or when they're older and look back and question, like, did we really want all of this information about their personal medical history online? There's a lot of discourse about this right now. So there's certainly a trade-off of privacy when choosing to share in a public way, but for these folks, the potential benefits of helping others might outweigh those risks. And lastly, future studies could look into trends in social media use by rare disease patients themselves, honoring their experiences and thoughts on this topic. So while this study focused on parents and other family members, we also had siblings, aunts and uncles, grandparents fill out our survey. Teenagers and adults with MPS that are old enough to run their own social media accounts are valued voices and incredible partners and advocates in these discussions. So I wanted to give a shout out to 15-year-old Zachary Thomas in Alabama, who, along with his mother, Brooke, advocated for MPS 1 to be added to state screening there. And they just started screening last month. So I think developing a similar study to understand how folks with rare conditions publicly share their own stories is an idea for a future study. Okay, just want to acknowledge my advisors, Nancy Sincata and Randy Zinberg. Thanks to Expecting Health for the chance to share a bit about my project today. These are the organizations that shared information about the study with their families. I had the opportunity to volunteer at a family day with National MPS Society last summer, got to hang out with families, hear about their journey. So I just want to acknowledge them as well. And I have my email address here if anyone would like to connect, talk more about newborn screening for MPS, health communication on social media, anything I mentioned here, would love to connect with you.
Incredible. Thank you, Emily. And thanks to all three of you again, just sitting here trying to take it all in. I think each of you, and not even necessarily planned in this way, touched on so many key issues that generally in the newborn screening community and system, we talk about often. Things like equity, things like privacy, education, readiness. All of these are topics that for quite some time, the newborn screening community has tried to tackle. So I think it's incredibly encouraging and motivating to see students like yourselves tackle these issues in your programs and help move those conversations forward. We have about 5 minutes, so I know we don't have a ton of time for questions. I do see one question from Natasha in the chat box, and this one is for Maya. You can probably see it yourself, Maya, but can you speak a little bit more to the difference between the overall positive views on newborn screening sequencing, but a clear sense that clinics are not ready for implementation? And that was actually my question too, is, you mentioned that 77% feel like they're not ready, and sort of, can you elaborate on that? What do they need, or what do we know about that?
Yeah, absolutely. Actually, for the sake of time, I did not mention. I didn't deep dive into this, but I actually had optional free text included in my Likert scale questions, and a lot of genetic counselors did qualify that they were interested, but they would not be ready because they don't know how this information is going to get stored in the medical record, who it's going to be accessible to. They're simply not ready because they don't have enough genetics providers and people who they think are educated to offer counseling related to a positive screen if there is a genetic component to newborn screening. And a lot of folks really mentioned that they just have no idea if their clinic would be able to be handle storing and coordinating follow-up for those specific individuals. So those were the main kind of themes that I was getting back about that. And also that piece about provider education. Someone suggests something like creating additional versions of ACT sheets for conditions to be added to the newborn screen, because they find that non-genetics providers may have some miseducation about how to follow up and follow people about this. So those were some of the reasons. Thank you for that question.
Thanks, Maya. Morgan, you want to tackle that next one?
Yeah, sure. So for folks that can't see it, it says, I love the idea of culturally adapted RUSP process. In your studies, have you come across other examples of a document or process being adapted to meet the needs and values of a different culture or community? This can be in healthcare or other sectors that impact people. So yes, one of the places we looked to was other LMICs that have had newborn screening successfully rolled out. One of those places is India. And Nepal shares a lot of the same culture with India. The challenge has been that there is a paucity of genetic data to look to understand like what are the most common genetic conditions at all. So we're sort of starting from a place of not even understanding, what do population genetics look like? But certainly looking to like other needs assessments and other culturally competent adaptations of, I'm trying to think of an example. It's not coming to me right now, but like different health promotion programs, those are widely available and something that we're utilizing, and yeah, thinking through what are best practices.
Thanks, Morgan. Emily, it looks like there are two questions for you. The first is, do you feel there are ways that newborn screening programs can or should connect with families through social media?
I think that's a great question, and I think there's a lot of opportunity to make connections that with families that are choosing to publicly share. I like the idea of working with those folks to help them share in a way that can make the biggest impact. And I think something we talked about in one of our discussions was this idea of doing things with patients, not to patients or for patients. And I kind of think that's relevant here, working alongside those folks that are willing and able to share their story publicly. I think it makes sense that newborn screening programs could work with them and connect with them. Let's see.
The second question says, did you notice a particular age range or generation of those that elected to utilize social media? I don't know if you saw kind of trends in a particular age or age group that was more or less likely to participate.
Yeah, so we had a pretty wide range of folks that answered the survey. I think we had 4 or 5 grandparents answer the survey that were in their 60s or 70s. So that was kind of a higher age range than maybe I was expecting folks to be using social media regularly. We did look at some analyses of which apps they use and their age. We also looked at the ages, the current ages of the children and their age of diagnosis. And, you know, some interesting trends that we saw in terms of which apps they're using, how frequently they're posting on those apps. Nothing statistically significant, which I think kind of lends itself to that maybe this population of social media users you know, shares online for different reasons. They're not kind of stuck in those maybe expected age groups for like TikTok or Instagram or even Facebook. So yeah, I have some more data and some numbers and things I could share in terms of that question.
Super interesting. I know we're coming up on time. There's one last question. So I'll throw this out there for all of you and then we'll wrap up. But, you know, each of you kind of in different ways tackled provider education. So the question is, any ideas on best ways to educate doctors or providers, other providers, with documents, webinars, etc. This is a great question and one we always ask ourselves. So feel free.
I think folks who I've spoken to are very interested in things that offer CEUs and CMEs.
I would agree with that. That is what I have found as well. And certainly I think interactions that bring together, you know, provider, similar to what Emily, you described, you know, I think wanting to have a connection, wanting to be able to connect with other providers and share, you know, share experiences is definitely helpful. But that idea of, you know, getting that CME or CEUs on the back end is definitely helpful.
Yeah, I was going to add, you know, some respondents in my survey mentioned that these support groups, the private pages, are really, they rely on them very heavily in the beginning. They almost feel like those are the experts because they have so much lived experience caring for their children. And sometimes those parents tend to, you know, like know more than the doctors. That was like a phrase we got a lot, that's why they use these private pages. And I think, you know, just being equipped to kind of know what's out there. Sometimes I feel like it can be sort of a blind suggestion, like, yeah, check out social media. And, you know, sometimes it's like this feeling like anybody can say anything on social media. And that's kind of the point. There's no way for us as providers to know exactly what might be out there. So I think just being equipped to kind of talk through some of these things with patients and help them get to a decision that's best for them, even like some of those complicated things I mentioned about those private groups too. It might not be for everyone. Sharing publicly might not be what's best for that family in that moment either.
Well, again, we want to thank all three of you for taking time, not just today to share your work with us, but I'm sure, what felt like maybe endless hours putting together these projects and completing this work. So congratulations to all three of you on amazing projects, and best of luck on, you know, whatever might come next following this work. And just thank you so much for highlighting all of these really key issues and areas for us. I think it's a really great example too of the work that students do. And as someone who's been involved in the newborn screening community now, students are really interested in doing work in this area. So I think it's a really good challenge and thing for all of us to think about are what are some of these research questions we have, and is there a way that we can continue to collaborate and partner with students to do things like this. So thank you, thank you, thank you. Please feel free to continue joining us on our next webinar. We have a couple of webinars planned for later this month. The next one will be next Wednesday, September the 11th. Where we will focus on empowering partnerships and specifically how a collaboration between a patient advocacy group and federal agency really has moved progress forward for the homocystinuria community. So please look for that. Join us. We'll be celebrating our Grace Award winner later this month and look forward to lots of fun activities. So happy Newborn Screening Awareness Month. And thank you again to all three of you, Maya, Morgan, and Emily, for joining us today. Have a great afternoon, everyone.